want to start your, no, to try to give your professional group starts such a long group of webinars. I think it's necessary. You know about all of our travel restrictions on the one side, on the other side. I think even if we were able to do a big meeting, I think a lot of these people which are registered, when I saw that, are probably not able to reach our meetings. So take it also as an additional way of education in this way. Well, we will start with 5 basic courses, and please consider this as learning a new language. It should be nice for you and important to listen to these first basic courses. If you miss any of these courses, you should be able to see them later on YouTube. I think it's necessary because later on we will go more into detail. So imagine you learn a language, and then with all these other probably 30 additional courses, you will be able to learn to use this language in different occasions. That's what we want to try to give you. I think you will meet most of the ISG members, which are approximately 140 in the moment. You saw at least this and probably also the next webinar, the concept of this one. We will in addition have always a controversy, which in this situation of the basic science courses, basic uveitis courses, not that exciting, I think, but this is very important later on when we come to the more sophisticated topics. We would like to suggest you to visit our website always before you register. Please keep in mind, we want to have these meetings mostly on the first Saturday of the month, around noontime in Europe, at least 1 to 2 o'clock, but it may change a little bit depending on the group where they are based. You will find some more hopefully interesting information on our website, for example, regarding your education possibilities, in which parts of the world you can join one of the ISU members for some kind of education. We even have now some kind of aid support of some of your patients. So check the website. It may hopefully give you some more information. So we hope that you enjoy the meeting. I introduce you to Vishali Gupta, who is managing the ISG together with me, and Mark Desmet, who just still didn't show up. I think he will join us later on, and we will run through the program. Have fun. Be a little bit patient to learn about uveitis. It's not super simple, but actually the goal behind, the aim of the whole project is actually, please don't be afraid of uveitis. If you know a little bit more, then it will support you tremendously, and hopefully it also will create some fun for you. So please enjoy. Vishali, can you take over?
Thank you, Manfred. And once again, on behalf of IUSG and also on behalf of Uveitis Society of India, I would like to welcome you all to this wonderful, wonderful series where slowly, over a period of time, all of us are going to learn a lot about uveitis. With this, it's my privilege to invite Dr. Rima Bansal, whose colleague we work together, see each other every day, to talk about anatomy of uveitis. Over to you, Rima.
Thank you, ma'am. So thank you very much, IUSG, and thank you, USI. It's a privilege to be a part of this basic uveitis course 1. So I'll be talking on anatomy related to uveitis. So uvea, as we know, is the middle coat of the eyeball. It's highly vascular. And if we look from interior to posterior, it has mainly the 3 parts: iris, ciliary body, and choroid. Now, uvea comes from the Latin word uva, which means grape. Because of its grape-like color, almost black, size and shape when stripped intact from a cadaveric eye. Why a grape? Because if the stem is removed from a grape, the hole that is created looks like the pupil and the grape is the eyeball. Coming to Iris comes from, as per the Greek mythology, it is the name of the Greek goddess of rainbow. It's a thin circular disc forming a diaphragm over the crystalline lens. A central aperture, 4 millimeters, which is the pupil, controls the amount of light entering the eye. So iris, the periphery of the iris, which is the root, is attached to the ciliary body. And as you can see here, it divides the space between the cornea and the lens into the anterior and posterior chambers. Average diameter is about 10 to 11 millimeters, and the iris is thickest at the collarette and thinnest at the iris root. Coming to the macroscopic appearance of the interior surface of the iris, it's predominantly divided into a posterior peripheral ciliary zone and a central pupillary zone by a zigzag line called the collarette or the iris frill. Collarette is the sign of fetal pupillary membrane attachment. The ciliary zone, as you can see, is the wider zone here. It has radial streaks of blood vessels and crypts, which are the depressions, nothing else but where the superficial iris layer is missing. So you can see the crypts here and here. They're arranged in 2 rows, peripheral near the iris root and central near the collarette. So the laser iridotomy is done in the areas of iris crypts where it's thin and minimal energy is required. Coming to the pupillary zone, which is a smaller zone and more towards the center of the central part of the iris, lies between the collarette and the pigmented pupillary frill and is relatively smooth and flat. The posterior surface of the iris as compared to the anterior surface is much more uniform and darker, and it has numerous radial contraction folds. Coming to the microscopic structure of the iris, from interior to posterior, it has 4 layers. The anterior limiting layer, which contains the cells like fibroblasts and melanocytes. Previously, it was known as the endothelial layer. It's deficient in the areas of crypts. This layer predominantly decides the color of the iris. And if it is thin and contains few pigment cells, the iris is blue. And if it is thick and densely pigmented, the iris is brown. The second layer is the iris stroma, which forms the main bulk of the iris tissue, has loosely arranged collagenous network, and has the muscles, which are the most important, the sphincter and the dilator pupillae, along with the vessels, nerves, and various cells. The sphincter pupillae muscle, we know it constricts the pupil. It forms 1 millimeter broad circular band in the pupillary zone of the iris. And you can see this is the sphincter pupillae muscle, and it is innervated by the parasympathetic fibers. The dilator pupillary muscle lies here. It dilates the pupil. It lies in the stroma of the ciliary zone and supplied by the cervical sympathetic fibers. The third layer, which is the anterior epithelial layer, it is the anterior continuation of the pigment epithelium of the retina and the ciliary body, and this is the one which gives rise to the dilator pupillae muscle. The fourth layer, or the posterior pigmented epithelial layer, is nothing but anterior continuation of the non-pigmented epithelium of the ciliary body. It forms the pigmented frill at the pupillary margin, where it becomes continuous with the anterior pigmented epithelial layer. The cells here are rectangular or pyramidal. The ciliary body is the middle part of the uveal tract. It's brown because of the presence of the melanin pigment, anteriorly confluent with the iris root, and posteriorly it has scalloped edges which are ora serrata and continue with the choroid and the retina. In cut section, if you look at the ciliary body, it's almost triangular in shape. You can see this. And if you look at the interior side of this triangle, it forms part of the angle of the interior and the posterior chambers. The middle part is where the iris is attached, and the outer side is the one which lies against the sclera and has suprachoroidal space in between. The inner side, which is divided into 2 parts, the interior one is about 2 millimeters, which is the pars plicata and contains the ciliary processes. And the posterior part is about 4 millimeters, which is the pars plana, which is smooth and also known as orbicularis ciliaris. On the outside of the eyeball, if you look at the ciliary body location, anteriorly extends from a point about 1.5 millimeters posterior to the limbus and posteriorly to a point about 7 millimeters temporally and 6.5 millimeters nasally. The pars plicata has about 70 to 80 ciliary processes, which have valleys of Kunt as the regions between these ciliary processes. Each ciliary process is about 2 millimeters long, 0.5 millimeter wide, and 1 millimeter high. The pars plana, it terminates at the ora serrata. It's a transitional zone between the ciliary body and the choroid. Histologically has double layer of epithelial cells. The inner layer is continuous with the neurosensory retina, and the outer is the one which is continuous with the RPE. Relatively, it's an avascular zone, and here is where lies the surgical importance of this area in terms of pars plana approach to the vitreous. Topographically, the ora serrata corresponds to insertion of the medial and the lateral recti muscles. Microscopic structure of the ciliary body has 5 layers if we go from outside to inside. The outermost is the supraciliary lamina, which continues posteriorly as the suprachoroidal lamina, anteriorly continues as the anterior limiting membrane of the iris, and the detachment of the ciliary body occurs through this layer. The second is the main layer of the ciliary body, which is the stroma, contains the connective tissue, the various muscles, nerves, cells, and vessels. The ciliary muscle has mainly 3 parts: the longitudinal fibers, which contribute to the aqueous flow, circular fibers, which help in accommodation, and radial or oblique fibers, which help in aqueous outflow again. The third is the layer of pigmented epithelium. As the name suggests, it continues with the interior pigmented epithelium of the iris and posteriorly with the retinal pigment epithelium. The fourth layer is the layer of non-pigmented epithelium, continuing anteriorly with the posterior pigmented epithelium of the iris and posteriorly as the sensory retina. And the innermost is the internal limiting membrane, which is the forward continuation of the internal limiting membrane of the retina. Ciliary body has 2 main functions, as we all know: formation of the aqueous humor, which is primarily by the ciliary processes, and the ciliary muscles help in the process of accommodation. The microscopic structure of a ciliary process almost same as that of a ciliary body. Like you have the capillaries, each ciliary process contains a network of capillaries within the center. The stroma, has the connective tissue. Outer pigmented epithelium continues as the Brooks membrane of the choroid. Inner non-pigmented epithelium and the internal limiting membrane. Now, if you look at the choroid, it is the posteriormost part of the uvea and the most widest part of the uvea, extends from the optic disc to the ora serrata. The inner surface of the choroid is smooth and brown and lies in touch with the RPE, and the outer surface is rough, which lies adjacent to the sclera. Now, if you look at the microscopic structure of the choroid, it has 4 layers: the suprachoroidal lamina, and the potential space between this membrane and the sclera is the one which is known as suprachoroidal space, which contains long and short posterior ciliary arteries and the nerves, and I'll be coming to that. The stroma of the choroid has loose collagenous tissue and the cells, and the vessels may form the main bulk of this layer. We see the layer of large vessels, that is the Haller's layer in this, the layer of median vessels, the Sackler's layers in this, and the veins in this layer ultimately drain into the vortex veins. The third layer is the choriocapillaris, which nourishes the outer layers of the retina and contains the fenestrated capillary walls. Brooks membrane is the innermost layer of the choroid, and which is further divided into 5 layers from internal to external: the basement membrane of the RPE, inner collagenous zone, elastic tissue layer, outer collagenous zone, and basement membrane of the choriocapillaris. Now, this is the overall microscopic structure of the choroid. When we see from outside to inside, you have the sclera here, the suprachoroid lamina, the Haller's layer, and the Sackler's layer. This entire thing is the stroma of the choroid. Then we have the choriocapillaris and the Brooks membrane. Coming to the choroidal circulation, it constitutes about 85% of the entire blood circulation of the eye. This choroidal blood flow is much higher than that in the retina and brain. It has a high flow rate and high capillary permeability. The posterior ciliary arteries, right down to the terminal branches in the choroid, have strictly segmental blood flow and behave as end arteries. There are watershed zones situated between the various posterior ciliary arteries, which has clinical significance among various ischemic lesions within the choroid. Coming to the vascular supply of uvea, there are mainly 3 sets of arteries. One is the short posterior ciliary arteries, which arise from 2 trunks from the ophthalmic artery. Each trunk divides into 10 to 20 branches, which pierce the sclera around the optic nerve here, and then they run in the suprachoroidal space and supply the choroid. They form the circle of Zinn, which encircles the optic nerve at the level of the choroid. The second set of arteries is the long posterior ciliary arteries, which are 2 in number and arise nasal and temporal to the optic nerve. They pierce the sclera and run forward in the suprachoroidal space to supply the ciliary muscle. They anastomose with each other and with the branches of the interior ciliary arteries to form the major arterial circle of the iris. The third set of arteries is the anterior ciliary arteries, which are about 7 in number, and they derive from the muscular branches of the ophthalmic artery. They pass anteriorly in the episclera, give branches to the sclera, limbus, and conjunctiva. Ultimately, the anterior ciliary arteries pierce the sclera near the limbus to enter into the ciliary muscle, where the anastomose with the two long posterior ciliary arteries, as I mentioned before, to form the major arterial circle near the root of the iris. We also have the minor arterial circle, which are formed from several branches of the major arterial circle, which run radially through the iris towards the pupillary margin, where they anastomose with each other to form the minor circle. So the venous drainage, we have a series of small veins from the iris, ciliary body, and the choroid, which join to form the vortex veins. There are 4 vortex veins, one in each quadrant. They pierce the sclera behind the equator and drain into the superior and inferior ophthalmic veins, and ultimately to drain into the cavernous sinus. So to recap, these are the important figures regarding the blood flow of the eye as far as the uveal tract is concerned, and the anatomy of the various parts of the uvea. And this is where the anatomical classification of uveitis given by Sun is based on. So you have anterior uveitis where you have inflammation of the iris ciliary body and so on. And we'll be having much detailed talk by Daniel later on this. So to summarize, the anatomy of uveitis is extremely important to know the nomenclature of uveitis, to decide on the pattern of uveitis and to understand it, and very essential in deriving the differential diagnosis of uveitis, and ultimately to understand the pathophysiology of the various uveitis as to why it is occurring in a particular compartment of the eye. So thank you very much.
Thank you very much, Reema. That was clear. And with this, we move on to John Campen. John will be sharing with us about the epidemiology of various types of uveitis. Over to you, John. John, you have to unmute yourself.
There we go. Can you hear me now?
Yes, very well. Thank you.
Good. Okay. One of the big reasons that the International Uveitis Study Group is interested in giving this course is because uveitis is mostly a preventable cause of vision loss. And those of us who have been practicing for a while have many experiences of sort of dramatic improvements. And so I would just encourage everyone to pay attention, because you can make a dramatic difference in patients' lives. And some of the unpleasant statistics I'll review, at least in terms of outcomes, can be improved greatly with treatment. These are just some of the nasty presentations that we might see, and many of these might recover extremely well to normal vision, except maybe the ischemic one. So just to review, we classify uveitis according to anterior, where the inflammation is mostly in the iris and ciliary body; intermediate uveitis, where it's mostly in the vitreous and perhaps arising from the pars plana or the vitreous itself; posterior uveitis, where it's involving the choroid and retina, although it may spill with dramatic inflammatory findings even into the front of the eye; and then panuveitis, involving all areas. And these IUSG criteria, I'll mention some in the epidemiology. So what is the extent of this problem? So just a little bit of epidemiological background. Most prevalence and incidence studies ideally would reflect a population-based study, where you can see what the number of cases is in the general population. And this has been done widely with many studies, but it's not been very useful in most cases for uveitis, because uveitis has a lower prevalence than many diseases, less than 1%. And so this kind of brute force study is a little bit difficult to be carried out. And it's only been done twice, both in southern India, associated with LV Prasad and Aravind centers. And so I'll mention those, but most of them come from other methodologies, especially sort of natural cohort studies like healthcare maintenance organizations in the United States, or in other parts of the world, where everybody is sort of covered within a system, gets all their care between the point of enrollment and departure within the system. And so it's like a natural cohort study. Other studies have used regional data where they just assumed that all the cases would come to the subspecialty center, which would tend to underestimate risk. And then there are some national surveys based on self-report, which we don't get into much, in insurance database studies, which depend on the reliability of coding of cases that probably tend to overestimate the burden. So let's just go over then the prevalence. These are some of the studies that I picked out, which I think are some of the better ones. And you can see that it's sort of clustering around sort of 75 to 80% in this area with one exception. These were panel ones where everybody was within the panel, and this was more of like a regional one. And this is an insurance database study, which we would expect to overestimate a little bit. Within the insurance study, they divided it between adults and children, and you can see that the prevalence within a one-year period is much more among adults than among children. And again, these are both probably a little bit high. This is sort of the combination of the two here. Looking from the population-based studies from India, and this is a different kind of prevalence where it's the number of people that have signs of active uveitis or else of scarring or other signs of prior uveitis at the time of examination. So it would be the prevalence of something that was clinically visible at some point in their life prior to the point of examination, so much more than a one-year catchment. So this is getting to 70 or 0.73% in the Andhra Pradesh study and 0.27% in the Tamil Nadu study. So you get bigger numbers that way. Now, if we look to the proportion of cases from these prevalent studies by the site, we see that the large majority of cases are anterior uveitis, sort of clustering around 80% in these sort of almost population type studies. Intermediate uveitis being much lower, only like 5 to 10%, and then posterior and panuveitis, sort of 15 to 20% of cases. And so these are the ones that people that are not specialists especially will spend much of their effort on, but these are the ones that are the most likely to cause visual loss, although all of them can. Gary Holland and his former trainees did a study some years back where they compared his experience at UCLA in a tertiary center versus their sort of general ophthalmology practices. And so in the general practices, it was about 90% of all uveitis cases, which were what they were seeing, whereas the tertiary one was attracting the more severe cases and had only about half being anterior uveitis. And this has been seen in many reports from tertiary centers about that much. Also, in the tertiary setting, the proportion that are chronic will be much higher because the ones that are remitting often can be handled by a non-specialist. Now, in the Hawaii study that Nisha Acharya led, they also reported the sort of clinical course, whether it was an acute remitting, recurrent remitting, or chronic form. And so about half of cases where it was known, sort of excluding the missing ones, were acute remitting. So that would be just one attack that they knew of at the time of the record review. These studies, they looked at codes and then they confirmed the cases by record review. And then recurrent was about a quarter, and then chronic was about a quarter. This was sort of higher than I was expecting when I read this paper. And so, but you can see about 3/4 of cases are remitting and therefore wouldn't need maintenance suppressive therapy, and about 1/4 would need suppressive therapy. Looking at the incidence then, which is defined as the number of cases per person year, or it's person year in this particular study, we see that most of the reports are clustering around 25 per 100,000 per year, and with one exception that was somewhat higher, which should have been a good study, I think, but maybe it was just a random difference. So around that range. And so if we summarize this in terms of the burden, and most of these data are from Western populations, pretty much all, the incidence of uveitis then is something like 25 cases per 100,000 per year. So that would be the number that have new active uveitis per 100,000 per year. The prevalence of having active uveitis, which might be either a new or a recurrent or a chronic case, that had cells or some other active inflammatory finding, about 75 per 100,000 per year. And so all of these rely on some sort of passive methods other than the two Indian studies, that they involve someone presenting for clinical care. And this might underestimate the incidence or burden, the incidence or prevalence, because sort of very mild cases that were asymptomatic or patients that just can't access care would be missed. The proportion that had uveitis at some time previously in their lives would be much higher, as we saw with the South India population-based data. And the data that we're talking about here are from Western temperate areas. And so in tropical areas where there are more infectious diseases that might affect, that might cause uveitis, we likely would see a higher prevalence and incidence than in the temperate regions. All right, let's go on to risk factors for uveitis. This is an area that is still somewhat emerging. It's fairly difficult to study. So from some of these studies we've been looking at, you can see that 2 of the 4 studies showed an increase in risk with age. This was the Northern California study, and this purple one was the Hawaii study. And so both of those, although the slope was different, they showed increasing risk with increasing age. The study from a veterans population was about flat over the ages study, whereas the Minnesota study from many years ago was more like a normal distribution with a peak in this range. The tertiary practices, they tend to see more patients in this range typically. And so maybe this is because the intermediate and posterior cases may be peaking around the sort of middle age time. Although in this case, the diffuse, which would be approximately panuveitis cases, did go up more with age. This was from the Northern California study. This is sort of, I wasn't really sure how to present this in a very interpretable way, but this is showing the proportion of cases in these studies that were female. And so the only reports in the young children were nearly all in females. As we got to older, it was sort of not as clear that the majority were female, but there was a tendency to have a little bit more cases in females, but in some cases it was even more in males, the red being the Hawaii and the blue being the California study. So female is probably a soft risk factor. If you look at the tertiary center reports, all of them pretty much show about 60 to 65% of the patients coming for tertiary care are females, and this is fairly typical of immune-mediated diseases. We know, however, that spondyloarthropathies tend to occur more in males, so it's not universal across all types of uveitis. Now, by race is sort of a difficult study. Other forms of eye disease seem to vary greatly by race. In the Northern California study, it's been reported that the US African Americans who are maybe half African genetically tended to have a higher risk. And in the Hawaii study, the Pacific Islanders or Native Hawaiians had the least risk, the Asians beneath that, and the white population the highest. The African Americans are very infrequent living in Hawaii. And so in the California study, Asians and whites were similar, and Hispanic was studied as well. So maybe it's higher among Africans, at least maybe from West African descent, that came to the United States. Hypovitaminosis D is an emerging risk factor for uveitis. This has been shown now in several studies for aggregated all types of uveitis, one specifically which involves some mechanistic considerations in Vogt-Koyanagi-Harada disease, and it's been reported in both white and black races, and there's some lab data to support this. So this is probably a risk factor, which suggests some potential treatment ideas, but treatment hasn't been proven. Female hormonal therapy, I was involved in studying from a large administrative database, and this was sort of a soft or sort of slight risk factor for uveitis. In one way we looked at it, there was a higher risk, and so this would be, and it was mostly seen among women over 45 and older, so probably with hormone replacement rather than birth control pills. So, but the effect size is fairly small, and so this is probably not very important for the majority of patients. I don't know that it's strong enough to say that you have to stop it either if you diagnose a patient and they're taking hormonal therapies. There's quite a lot of drugs that have been reported to be associated with an increased risk of uveitis. And the ones that I've bolded here, it occurs fairly frequently with those a few percent or higher. The ones that I've italicized are not very frequent, but are ones that would be important to know for board exams and important to think about if you see a patient who presents with uveitis for the first time and they're taking these drugs. And then many others have been reported as well. So summarizing the risk factors, older age may be a risk factor, especially for anterior uveitis. Maybe when you get into sort of post-operative uveitis, this is going to be an older age, so that could be a factor. And there's been heterogeneity of results about that. There's sort of modest evidence for a higher risk with female sex or female hormone replacement. Smoking, I didn't show a slide, but it's been associated with an increased incidence and also with increased disease activity. So it's good to get your patients to stop smoking for many reasons, including uveitis or better uveitis outcome. Possibly higher with African American race, but it's not clear that this is generalizable to all of Africa, which is very genetically heterogeneous. And the Pacific Islanders seem to be have less risk. Vitamin D deficiency and certain drugs also appear to be risk factors. So if we think about a lifetime risk, probably the risk across the lifetime might diminish with many years, but we might be getting into a lifetime risk of 1% or so, possibly even more. The risk might be higher among Africans, and in tropical or sort of tropical low altitude countries, the risk is probably more. And so the burden is probably higher in those regions of the world. But just projecting the number of cases from the temperate derived data, we might see this many, so about 1 billion cases, or out of 1 billion population in sub-Saharan Africa, maybe nearly 1 million active within 1 year, and maybe 10 million lifelong. And you can see the estimates for your particular region of the world, with potentially 5.7 million people active in a particular year and over 75 million worldwide developing uveitis in their lifetime based on this projection, which is subject to some imprecisions. Now, what about visual loss? So we don't really have great data about the visual loss, and visual loss is often reversible in these cases. But based on some registered data in 30 years ago, people were saying around 10% of blindness in the US and the UK. This might reflect a higher burden because before steroids and other treatments were available and before tertiary care had been figured out, which didn't really begin until the 70s, a lot of cases may become blind. So probably things are doing better now. But in areas where uveitis may be neglected, which we're trying to alleviate that by this program, the visual loss per case is probably higher than in developed countries. The impact per case also may be higher than with age-related diseases like cataract and macular degeneration because people may be blinded at an earlier age. And so the years of preventable vision loss, which I don't think has really been reported, would be higher with uveitis relative to the number of cases. And the costs of controlling it may be high as well because there may be expensive drugs needed and a high intensity of management. So really the only data we have from a population-based study are from the study in Andhra Pradesh. And here it was 270 per 100,000 with low vision and 160 per 100,000 with blindness by the US definition. It would be less with the WHO definition. So not trivial impact on the general population. If we project this out, we might have in sub-Saharan Africa about 3 million with low vision and about 1.7 million with blindness, and nearly as many in Europe, and around 20 million worldwide with low vision due to uveitis and 12 million with blindness by the Western definition. So visual loss is substantial, and overall, we very roughly say that uveitis may be the 5th to 7th leading cause of visual loss. And it may be even more than that in developing countries if most patients don't get treatment and the burden is higher because of infectious diseases. But the impact may become less or more favorable as treatment is scaled up globally. And just following through with that, I would like to just argue the thesis that most severe visual loss due to uveitis probably is unnecessary if patients can access good treatment. And I base this on some fairly recent data showing prospectively in this group of intermediate posterior and panuveitis cases that basically the average patient was stable over time, although some outliers lost vision over time under tertiary management. And in another tertiary series, we saw that patients actually tended to improve a little bit at the beginning and then be stable to slightly improved out through 5 years. And so really none of the groups of patients were really worse than at presentation by 5 years on average. This is data from the site and the MUST studies, and this is sort of showing like a time to event type thing, but this is showing the proportion over time that lost or gained 10 letters or 2 lines of vision. And so really more patients are gaining vision than losing vision, and then a large number are stable over time. And so a lot of patients really do well if you follow the principles that are going to be taught in this course. Just some other points here from this risk factor study, which is in press now. These are some of the interesting risk factors that doing cataract surgery before coming to tertiary care was associated with 3 lines worse visual outcome. And if it was done during follow-up, it was associated with an improvement, probably because at the time of presentation, they had the cataract already. And then also the duration of uveitis before coming under care was associated in a dose response manner with poorer vision the longer it was before they came to tertiary care. And then active uveitis also in a time updated kind of analysis is associated with worse visual acuity, which is probably pretty obvious. So these studies then show that the average patient with uveitis is stable or even gets better with appropriate care, even for severe cases that were willing to enroll in a study where they would be randomized to immunosuppressive therapy or Retisert implant therapy, and that proper uveitic care has substantial benefits. And so that's what this course is all about. But it's not the center, it's the treatment that matters most. And so if you're able to master these principles, you can accomplish great results with your patients too. So what can we do then? We want to use corticosteroids as the backbone for induction therapy, that is suppressing the active inflammation, and this will be gone into in great detail in future talks, with early use of immunosuppression when indicated for maintenance. And then we have to find the cases. And so if you develop a network to attract the patients to your practice and make it easy for them to access your care, once you become an expert in managing it, then this can have a huge benefit for the population, which is a big part of my interest in serving in Ethiopia. Thank you very much.
Thank you, John. You may stop sharing, please. Thank you. John, there is a question for you in Q&A box from Mary, and she actually wants you to show the slide on drug-induced uveitis again, which may not be possible considering the kind of the thing, but you may answer to, okay, you can do that. Perfect. We'll take a moment here. She wants to see the slide where you have talked about drug-induced.
This one.
Yeah, here it is.
Quickly.
Can you see it?
Other questions will be towards it. Yeah.
Okay.
Okay. I guess that's it. Maybe she wanted to see. Thank you very much, John. We all know how important is history taking, but equally important is to know the history of uveitis, where all it began. And of course, we have our president, Manfred, talking to us about history of uveitis. Before we go on to how do we take the history in a patient of uveitis. So over to you, Manfred, about history of uveitis.
Hi, welcome again to you. So how did we reach the situation we have today? Let's think about what happened with uveitis during the years. Well, this is an old plate from the Romans, and we should be aware that even before the Romans, people knew what about uveitis going on. So what is the beginning? The first thing we have in a written form is 1700 before Christ. There's a first ophthalmological document, and it contains information about ocular inflammation by a doctor called Pepi Ahn or Iri. This person lived probably 2400 before Christ, and he was called the palace eye physician. And as you see, everything here started in Egypt. So this is one of the pictures I got in a bad quality. So whoever can read these beautiful pictures, I would be happy to get some information what they say here. But then the Ebers papyrus was found a few hundred years later, 1500 before Christ, and it shows therapies. And of 237, 100 of them cover ocular disorders already. Well, you should not go too much in the type of treatment. It sounds a little bit curious and well, I think it may be a real challenge to survive the doctors at that time. So they suggested zinc, antimony, copper, aloe, myrtle, which is probably the best one in this regard, malachite, ink powder, galena, and jarret, whatever this is. And they already mentioned cynic here. They use compresses with lotion of salpeter and ebony wood shavings. These were the old Egyptians. This is one of these papyrus rolls of that time. And then we go on to the Romans and Byzantinians, and they know how to live at that time. You see here, they started with cannabis, opium, extract of plants, whatever this is, but then also laxatives and enema, something which you'll find probably until today in some societies. I'm not sure about this one. And then the Byzantinian times, which covers the 4th to the 15th, 15th century before after Christ. They used also opium, milk, honey, oil, mother's milk, the help for everything, probably therapy for everything, proteins, iron, copper, drops of pepper, bloodletting, and different antidotes with oral and rectal ways. But then we finally reach Mr. Scarpa. Scarpa from Italy, he's the first doctor who presented a case report about uveitis. So this patient has hypopyon, definitely, I think, uveitis, and he was treated with leeches on arms and legs and besides the eyes. He also used small bags of gauze filled with emollient herbs, boiled in milk with a grain of Antimonium tartarizarum, whatever this is. And in addition, he used drops of vitriolic collyrium with mucilage of quince seed and probably 100 different other things, which is his own secret. And he reported about the result, complete remission on day 11. Well, actually, I think the result with moderate degree of light is not something we would accept nowadays. Oh no. Yeah. But then we reach the 19th century, and then in 1813, Joseph Baer first described the association between glaucoma and something he did not call uveitis, but intraocular inflammation. And in 1830, it really becomes more and more scientific with the Scottish person Mackenzie, who presented the first English description. He used in his patients mydriasis with belladonna tincture, sounds familiar, I think already, bloodletting, laxatives, etc. Well, that's from the medieval still left. But he also was the first one who described scientifically sympathetic ophthalmia, something which was reported already from Hippocrates and Galen in the medieval. Mackenzie then has a first description, and probably you know that Louis Braille from France, who lived until the middle of the 19th century, was one of the most prominent patients with sympathetic ophthalmia, and he developed finally the Braille system for blind people to read. Now let's go to the 20th century with a very curious treatment, which is called fever therapy. And have a look for this one, intramuscular injection of milk or intravenous injection of typhoid antigens. Well, at least these doctors reported good results. And this is a picture of our own old Tübinger clinic, which we have left a few years ago. And you see probably in front of the clinics, here the green the green gardens we have, and people told me that well, half a century ago, this was a place for people with uveitis getting sun bath and to develop some kind of fever with this one. So it's all not that far away. But then modern history probably starts also with Ernst Fuchs, the chief of Department of Ophthalmology in Vienna, who described the Fuchs uveitis syndrome, which, to be honest, was already described also by Lawrence 60 years before. And we now know that Fuchs uveitis syndrome probably is induced by an immune reaction to rubella, probably in some South Asian countries by CMV. Then in 1937, Monsieur Bechet from Turkey described the Bechet's disease, which also was previously described also by the Greek Adamantiades. And then things become really interesting regarding treatment. Probably the first real good treatment in uveitis was Hench and Gordon in Boston, which became a very important part of uveitis research in the next years. They used corticosteroids for rheumatoid arthritis. And one of the most prominent persons was Raoul Daffy, one of the most prominent painters of that time from France. He also was a rheumatoid arthritis patient, and he was not able to paint anymore. But with corticosteroids injections, he really became more or less healthy again. And for saying thanks to his doctors, he did a painting called L'Art Cortison, and he gave this to his doctors. Well, by the way, it's all fantastic, but it's not that fantastic that he ended up with gastrointestinal ulceration due to his corticosteroids, and he died by this one. So I think we should learn these lessons. The basis for today then started in the second part of the last century when they decided also to have a intermediate uveitis. They published tremendously about that one. Then in the 60s, we had the start with immunosuppression, always looking for rheumatologists, which are actually the most important doctors for us when it comes to immunosuppression nowadays. And from that time on, we also had a definition of some more disorders like the Poisson-Schlossmann syndrome, which nowadays is pretty associated in most cases to CMV virus, APMPPE by Donald Guess, and this could get continued. We finally were able in the last 40 years, 30, 40 years, to differentiate these different forms. You heard about anterior, intermediate, posterior with probably pan-uveitis in addition. I think the ISG started the first real criteria in 87, which were supported and prolonged by the Sun classification with additional criteria. And now we are also in the time of good guidelines for acute retinal necrosis, probably for vitreoretinal lymphoma, Tino syndrome, JA, something you will hear about in the coming webinars in the future, so that we now are really able to differentiate depending of the most effective part of the eye, the term, which part of uveitis it is. So I hope I was able to give you a short summary about the history of uveitis. Hope you like it.
Yes,
Thanks.
we always love listening to you. So with this background knowledge of epidemiology, history, anatomy, we move on to real-world management of uveitis patient. And this talk is actually what is going to build on now in future webinars. So with this, I would like to welcome Daniel, and Daniel is going to talk about differentiation of anatomical types of uveitis. Over to you, Daniel.
Thank you very much, Vishali, and congratulations to the IUSG for this very important uveitis education initiative globally. Well, uveitis, as you all know, is a very complex group of heterogeneous conditions associated with different etiologies, with different treatments as well, and may be the first manifestation of potentially severe systemic disorders. The anatomic classification of uveitis was proposed by the USG in the late 80s and it's basically based on the presentation, on clinical presentation, on slit lamp, and on fundus examination. So that anatomic classification divides uveitis into anterior, intermediate, posterior, and pan uveitis. Anterior uveitis is defined as that associated with primary inflammation in the iris in the anterior part of the ciliary body, revealed on clinical examination by the presence of inflammatory cells in the aqueous, in the anterior chamber of the eye. Intermediate uveitis is characterized by inflammation primarily in the posterior part of the ciliary body and in peripheral retina, and that reveals clinically by the presence of inflammation that is predominant in the vitreous and in the peripheral part of the retina. Posterior uveitis is characterized by primary inflammation in the choroid and also in adjacent structures such as retina, optic nerve, and even the vitreous. Is on clinical examination, usually we are able to see infiltration in the posterior part of the vitreous, as well as lesions in the retina and the choroid. And last but not least, panuveitis is characterized by uniform, diffuse inflammation of the whole uveal tract, involving the iris, the ciliary body, and the choroid and retina. And in these cases, we see inflammation in all parts, in all compartments of the eye. Significant inflammation in the anterior chamber, in the vitreous, as well as in the posterior segment in the retina and choroid. The anatomic classification of uveitis has significant etiological, therapeutic, and prognostic implications. We know already prior the main etiologies of each one of these anatomic types of uveitis. This is an example, a patient presenting with decreased vision, granulomatous keratic precipitates, as you can see, anterior chamber cells. But once we look at the fundus, we see an exudative vision adjacent satellite to a pre-existing retinal choroidal scar. This is prototypical of a toxoplasmic chorioretinitis. So this completely changes the anatomic classification to a posterior uveitis. So anterior uveitis, as I said, is characterized by inflammation in this part that is shown histologically here. Usually on slit lamp examination, we see infiltration of inflammatory cells floating in the aqueous humor. These cells, they may aggregate in clusters that may deposit in the posterior part of the cornea, forming the so-called keratic precipitates that are collections of these inflammatory cells. This is the most common type of uveitis worldwide, as John showed previously today. It's associated with multiple causes, but indeed most cases of anterior uveitis is of idiopathic or undetermined cause. And it may be, as other types of uveitis, the initial manifestation of systemic inflammatory and infectious disorders. Patients usually complain of symptoms that are associated with involvement of the anterior segment of the anterior chamber of the eye. And on examination, in addition to keratic precipitates and inflammatory cells, we may see hypopyon, pupillary membranes, iris nodules, and even anterior and posterior synechiae in cases of more significant anterior segment inflammation. It's fundamental to look carefully to the fundus, because one may inadvertently label a case of anterior uveitis without carefully looking at the fundus. So if you find changes suggesting other predominant or the significant sites of inflammation, such as no banking, for example, this also changes anatomic classification. So this is now a case of intermediate uveitis. Intermediate uveitis is characterized by inflammation primarily in the posterior part of the ciliary body, involving the peripheral vitreous and the peripheral retina. Usually that on clinical examination is revealed by infiltration of cell vitreous haze, even formation of snowballs and snow banking. This is a rare type of uveitis. It does occur more frequently in younger individuals, and usually the eyes, they are relatively quiet. The patients don't complain much of involvement of the anterior part of the eye, but mostly of the vitreous. So even though we may find, for example, autoimmune endotheliopathy, that is an opacity in the corneal endothelium associated with chronic inflammation, mainly in cases with snow banking. So inflammation of the vitreous is dominant in intermediate uveitis. One may find the formation of snowballs, which are small granulomas that float in the vitreous. These may also be found in the posterior part of the vitreous, as you may see, and also lead to this exudation in the pars plana that is called snow banking, that is made up of condensed vitreous, fibrogliovascular proliferation, and may indicate chronic long-standing inflammation in the pars plana. Also, what is very frequent is the involvement of retinal blood vessels, manifesting by either periphlebitis and also frequently a peripheral microvascular leakage on FA. The optic nerve as well as the macula may be involved in the fall of edema, as you can see in these images. And last, the posterior uveitis is characterized by primary inflammation in the choroid, but also affecting adjacent structures such as retina, blood vessels, the optic disc, and even the posterior vitreous. Patients may complain of some changes in the anterior segment, but what is dominant is symptoms associated with posterior segment involvement. We may see inflammatory cells in the vitreous, but usually we find lesions in the retina and in the choroid. So this is an example of a patient with Bartonella neuroretinitis, also with a focus of retinitis superiorly, that we see that the epicenter of inflammation is located in the retina and in the optic nerve, with exudation of inflammatory cells to the posterior vitreous close to the hyaloid. Some good examples of posterior uveitis: toxoplasmosis, that is characterized by a retinal choroiditis with involvement of adjacent structures. Among the non-infectious conditions, birdshot chororetinopathy with primary involvement of the choroid as well as of the retina with significantly persistent chronic intraocular inflammation. Last but not least, panuveitis is characterized by diffuse inflammation involving all the uveal tract, the choroid, the ciliary body, as well as the retina. So patients complain of symptoms involving the anterior segment and also the posterior segment. On examination, we see significant inflammation in the anterior chamber, keratic precipitates, even formation of hypopyon more rarely, synechia, iris nodules. The anterior vitreous is also significantly involved, as well as the posterior segment of the eye in the form of vitreous haze, lesions in the retina, in the choroid, and the retinal blood vessels as well. So the prototype of this group is Vogt-Koyanagi-Hara disease. This is a young female with rapidly progressed decreased vision in both eyes. So on clinical examinations, she has significant infiltration of inflammatory cells in the anterior chamber. She has also bullous retinal detachments in both eyes with significantly inflamed choroids. You see the significant choroidal thickening on OCT as well as on B scan. And another example of panuveitis is a patient with significant inflammation in the anterior chamber of both eyes, significant vitreous haze, and had skin lesions, discriminated skin lesions, highly suggestive syphilis. He came up with a positive serology for syphilis, as well as co-infection with HIV. So in conclusion, the anatomic classification of uveitis is essential for an optimal diagnostic approach of intraocular inflammation. It has significant etiologic, therapeutic, and prognostic implication, but it is dependent on a very careful slit lamp and fundus examination that does allow us to recognize clinical patterns, to elaborate a list of differential diagnoses, and being a basis for further investigations. Thank you very much for your attention.
Thank you, Daniel. We now move on to the continuity of what Daniel told us about history, identification, and next speaker, Peter, is going to talk to us about how history of the patients may help in the type of uveitis, the types Daniel just told us about. And it's late night for Peter. Thank you, Peter, for being with us in the middle of the night. Thank you.
No trouble. Well, good evening from late at night in a summer evening in Sydney, and good morning and good afternoon and good evening to everybody who's listening. It's a pleasure to be part of this symposium. So I've been asked to talk about how does the history help? So the aim of the process overall in sorting out a patient with uveitis is to identify the cause, and importantly in identifying the cause, be it infective, inflammatory, or some sort of neoplastic process, what's the most acute, baddest sort of threat to vision that we need to worry about? And that's often an infectious process. And the way that we do that is by a careful clinical assessment, history, examination and review of systems that helps us to either recognize a specific disease or syndrome or come up with a reasonable differential diagnosis that we then do selective investigations to sort out. Is my screen share working? Yeah.
Peter, you were sharing it before. It's no longer. And you have to go to slideshow. It was on slide sorter mode. That's okay.
Is it
perfect
working now? Yep. Okay, sorry. Yeah, so basically what I want to try and do is go through my system for taking a history and talk a little about the sort of critical relationship between the history and the examination. You can't really separate them in the real sort of world when we're talking about evaluating a patient. So what I do is I actually have these 8 groups of things that I always think about when I'm taking a history from a patient with uveitis. And I actually, on a sheet of paper, divide it up into these 8 boxes and then go through each of them to make sure I sort things out properly. Age is important because age alters the sort of likely causes, as we heard from John Kempen's talk. Occupation is important because it tells us clues about what sort of lifestyle factors might be important and how reliable the history might be. Ethnicity, again, as John Kempen mentioned, is also important and alters the potential differential diagnosis. Where you've lived in the world and places that you've traveled to and lived for any length of time is also important, as is family history for things like B27 related disease and a family history of autoimmune disease. This somewhat sort of humorous slide, or poor attempt at humor, is just to remind us that it's a privilege looking after our colleagues and their families, but these are often, unfortunately, very challenging patients for both the patient and the doctor to look after. And so we really need to identify our high-risk patients. And I always worry about looking after my colleagues and their families, and also I worry a great deal looking after lawyers, but the rest is just humor from my residents. But I think it is an important point to think about very carefully what the patient does that we're looking after. In terms of medications, that's a critical part of the history. Again, as John Kempen pointed out in his talk, there are a range of drugs that can cause uveitis. Medication history gives us a really important clue as to systemic diseases the patient might have and comorbidities and whether or not the patient's immunosuppressed. Being allergic to a drug is obviously important, so we don't prescribe that. But in general, adverse reactions to drugs, food intolerances, allergies, and other unusual reactions are common in patients with systemic autoimmune diseases, particularly, for example, Sjogren's syndrome. So it can be an important clue that this patient might have some form of systemic autoimmune disease. If we turn now more to the actual history of why the patient has come to see us, the presenting illness, obviously we want to go through the history and the tempo of the disease and its duration and the symptoms in detail. We also want to go into their past ocular history, where they've had any surgery, where they're having intravitreal therapy, history of trauma. But importantly, as has been pointed out before, one of the focuses of our history is to try and get a feel for the pattern of the uveitis using these descriptors that were put together as part of the SUN study. Was the onset sudden or insidious? Was it an attack of limited duration? Was it something that's persisted and persisted? Is it just a single one acute episode that the patient has had, or are they recurring acute episodes where the disease goes into remission and you can stop treatment and then it relapses? Or is it just a chronic persistent inflammation that's kept going since it began? If we look at the systemic aspects of the history, I just ask the patients what systemic diseases they've got. Often eye patients don't think that it's important to tell us about other diseases like sarcoidosis that they may have, or Behçet's disease, or that they've been exposed to TB. So we have to go through and ask them whether they've had specific diseases that are important to us. And it often takes 2 or 3 goes before they remember some of these. Obviously ask them about any reason they've been in hospital, surgery that they've had. Asking about surgery always reminds me to ask patients whether they've had any recent medical interventions or any dental surgery, which is often a thing that people forget to ask about. A travel history, as I mentioned earlier, is important. Any sort of at-risk behaviour, recreational or IV drug use, at-risk sexual activity, other risks for HIV infection, blood transfusions, travel to parts of the world where medical care may not be available as readily as it is in other parts of the world. And always think about whether the patient might be immunocompromised. Are they on treatment for cancer? Have they had an organ transplant? Are they on immunosuppressive drugs for arthritis or inflammatory bowel disease? Is there a past history of malignancy? In terms of the systems review, there are a number of different approaches that you can take. Some uveitis clinics and specialists have a very broad patient-completed questionnaire that they often get the patient to complete before they come to see the further consultation. Other centres just use a very broad, long, non-directed, comprehensive systems review. But many of us use a much more targeted systems review that's based on a combination of the history, the ocular exam findings, and the pattern, the phenotype of the uveitis. And that's certainly what I prefer to do in nearly all of my patients, because the history and the examination really help you to focus in on what are the important systems review questions you need to ask. So typically I'll start taking the history and start examining the eye at the same time, because what I find when I examine the eye, as Daniel mentioned in his talk, is the vitreous involved? Are there lesions at the back of the eye? Is it a hot eye? Is the vision down? That will guide the sorts of diseases that you're thinking about and the disease processes, and will help you to target further history and further systems review onto what are the important differentials that you need to exclude. So I thought I'd just show you 2 representative types of cases to show you how that process works. So here's a patient who's presenting obviously with an acutely inflamed eye, bound down pupil. What we would mostly assume is anterior uveitis or pan-uveitis. And so the history will tell us that this was a sudden onset, probably limited duration episode that's presented with a red, painful, photophobic eye, lots of signs in the anterior chamber, cells, flare, fibrin. But as Daniel said, the critical thing here is you must dilate the pupil and examine the posterior segment. Make sure there are no retinal lesions, no peripheral retinitis, no vitreous snowbanks, because the only way you can diagnose anterior uveitis is knowing that the rest of the eye is not involved. And then once you know it's anterior uveitis, then you can go back and revisit the history and focus in on the sorts of diseases that you need to exclude or think about with anterior uveitis. And we'll obviously go into this in more detail in subsequent webinars. So if it's anterior uveitis, this is the way I'm starting to think while I'm talking to the patient. I want to know, is it unilateral? And if it's strictly unilateral, be it a sort of acute episode, recurrent acute episodes, or chronic, I'm always worried that it may be some form of viral herpetic uveitis or Fuchs. And as Manfred said, these may all be much more closely related than we used to think they were. If it's unilateral, alternating recurrent acute anterior uveitis, that always makes us think of the pattern of disease that we most commonly see associated with HLA-B27 related illness. But there are a large group of patients who have this phenotype who are either HLA-B27 negative or don't have a systemic B27 related disease. But identifying the pattern of uveitis is really important. Bilateral disease makes us think of different disorders. Chronic disease makes us think of different diseases. So getting history about the phenotype is really important. And of course, never forget syphilis, which can look like anything. So again, we go back and target our further history and systems review on the fact that it's anterior uveitis. So particularly in the systems review, we want to find out, does the patient have inflammatory back pain, arthritis, psoriasis, inflammatory symptoms to suggest inflammatory bowel disease? Have they got mouth ulcers and genital ulcers to make you think of Behçet's disease? Is there a history of a triggering infection, either genitourinary or gastrointestinal, that might go with a reactive process? Is there a family history of B27 disease? Have they had new sexual partners, patients who have sex with men, so that they're at risk of high risk of syphilis or HIV infection? So these are the sorts of more targeted history and systems review that you take once you're happy that it's anterior uveitis. Just to remind you about inflammatory back pain, it's an important and usually relatively straightforward symptom to elicit. It tends to begin in younger people. It's persistent. Episodes of inflammatory back pain often persist for months. They're worse at night, they're worse at rest. They often wake the patient up early in the morning. The patients have early morning back stiffness when they wake up that can take anything up to 1 to 2 hours to improve. And the key thing is that inflammatory back pain improves with activity and exercise, whereas most other forms of back pain get worse. And that's a key differential. And these patients with inflammatory back pain have often had an enormous number of unusual and weird diagnoses and treatments. And it's not until they develop uveitis and we take this history that it becomes clear that they've actually got ankylosing spondylitis or psoriatic arthritis. And we sort of are really important at making the diagnosis. And the Dublin Uveitis Evaluation Tool and Study is very useful and a great way of thinking about this. And they have similar sort of criteria. So I'll finish by just showing you someone with posterior segment uveitis. This is the sort of patient that you often look in and think, oh my heavens, what could this possibly be? We know that these severe vision threatening types of uveitis are much less common than anterior uveitis, a very wide potential range of causes. And again, because there's such a wide range of causes, we have to go back to first principles. History and examination, clinical assessment will help us to sort out exactly what's going on. Daniel's gone through the different types of phenotypes of uveitis that we need to worry about. What I always think about when I'm sort of evaluating a patient like this is try and work out from my examination, is it retinal or choroidal? Is it unifocal, multifocal, or is it diffuse? Because each of those exam findings helps to clue me into a particular group of diseases or spectrum of diseases that I want to rule in or rule out. And that then helps to guide my systems review and my additional history taking. The other important point is how the patient presents. There's this uncommon but severe, rapidly progressive loss of vision and severe uveitis that's very important for us to recognize and deal with. Other patients present acutely, as Daniel said, while others, say, for example, birdshot, present very insidiously with just floaters and slowly changing vision. And the presentation, the tempo, and those sorts of descriptors are very important. So I'll just finish off with this sort of urgent or rapidly progressive severe vision loss and severe uveitis, what in my hospital is often called the Friday night special, because these patients usually come in towards the end of the week. And the differential diagnosis that you need to keep in your mind is this group of diseases here. And importantly, most of them are infective, and particularly herpetic retinitis and infective endophthalmitis can be rapidly progressive, severe threats to vision. So you need to recognize these, or recognize that they could be the cause, and treat the patient appropriately. The way to sort this out is using our algorithm of history, examination, and then going backwards and forwards between the two and asking more and more probing systems review questions to sort this out, because the history is critically important in sorting this out. If it's infectious endophthalmitis, they may be on intravitreal therapy. They've got a history of systemic illness and systemic sort of sepsis. They've been in hospital, they've had surgery, they've had some other major illness, or there may be significant at-risk behavior, intravenous drug use. If you're worried it could be tubercular-related uveitis, certainly in my part of the world, 95% plus of the patients we see in Sydney and in Australia with TB-related uveitis are migrants from an endemic region. We live in a global village these days, so, or at least we did until COVID. So we need to be aware that of where people have come from, and have they come from an endemic area for TB. We always have to think about syphilis and at-risk behaviour, men who have sex with men, new sexual partners, unprotected sex, important risk factors for syphilis. And it can often take 3 or 4 rounds of history taking to build up a good enough relationship with the patient for this to become uncovered. Obviously, we do syphilis serology as well. Herpetic retinitis, acute retinal necrosis. The history is often really non-specific unless there's a history of organ transplantation and immunosuppression or some other immunosuppressive illness. The same with toxoplasmosis, typically occurs in an otherwise well patient. Behçet's disease, again, the history of mouth and genital ulcers, and possibly Silk Road ethnicity are the major things in terms of sorting this out. As I mentioned earlier, where it is it focal, is it multifocal, is it focused on the retina, or is it focused in the choroid, are important clues as to the likeliest causes of this sort of severe uveitis. But the critical take-home message is the history and the examination need to be thought as one sort of related process, and each helps the other. And this clinical assessment is the absolute cornerstone of sorting out our patients with uveitis. So thanks very much for your attention. I hope that was useful.
Thanks a lot, Peter. And with this, we move on to Daniel again. And, the questions being asked already in the question, what are the minimal investigations we should be doing for our patients?
Thank you, Vishali, and again, good morning, good afternoon, and good evening for some of you. As Peter nicely showed, medical history and clinical examination are of utmost importance in the approach of patients with intraocular inflammation. So the investigations we have are usually regarded as complementary. However, they may be quite useful to define the etiology of uveitis, to help us diagnose systemic underlying conditions, to help us exclude relevant differential diagnosis, and also to help us assess the extent, severity, and of intraocular inflammation, as well as of its complications. It also may be useful to help us assess treatment response as well as side effects of treatment. There is no magic universal standardized protocol for investigating patients with uveitis. The optimal approach should be individualized and based first on the anatomic and clinical classification of uveitis, on the establishment of a list of relevant differential diagnoses, then proceeding to a careful selection of diagnostic tests to be employed, keeping in mind the advantages and disadvantages of each one of these tests. Starting from non-specific investigations, a mere CBC is usually employed in the initial evaluation of patients with uveitis. In those with parasitic diseases, we may find peripheral eosinophilia, and the CBC may also be helpful to assess side effects of treatment. This is an example of a patient we saw many years ago, a man with bilateral granulomatous anterior uveitis in both eyes, and the mere CBC revealed Grumper cells which are diagnostic of chronic lymphocytic leukemia. Proceeding, we may also have the help of inflammatory markers such as ESR and CRP. These may indicate inflammation at the systemic level, which may be associated with intraocular inflammation. Also, metabolic liver panels, as well as other enzymes, may help us in the diagnosis of systemic underlying conditions, as well as in the assessment of side effects of treatment. Serological tests are frequently employed to help us assess exposure to or exclusion of infectious agents. We usually test specific IgG, IgM, and IgA, and also keeping in mind that HIV co-infection should be entertained in cases, especially in atypical cases, as well as those that frequently are associated with HIV co-infections, such, for example, CMV retinitis, syphilitic uveitis. We may also assess intraocular synthesis of specific antibodies to these infectious agents using the so-called Goldman-Whitmer or Whitmer-Desmond coefficient. So we measure specific antibodies in the aqueous humor and correlate this level with the level of antibodies in the serum. Then we may find results which are supportive of intraocular production of specific antibodies. Last but not least, serological tests may also help us look for autoimmune and autoinflammatory markers, which may be helpful for the definite diagnosis of some underlying systemic conditions. Genetic investigations may also be helpful. The most frequent examples are HLA B27 and A29, which are very helpful in the diagnosis of anterior uveitis and of birdshot retinal choroidopathy. Patients with NOD2 mutation in Blau syndrome are also another example of genetic tests that may be employed in some specific cases of uveitis. A cutaneous test, the most widely used one is the TST, the tuberculosis skin test, also called MAN2, that we inject the PPD inside the dermis and measure the extent of induration. This may be indicative of mycobacteria infection. For patients with Behçet's disease, we may also use the so-called pathergy test, that we make a needle prick and then measure the induration to this mechanical stimulus to the dermis. A simple urinalysis may help us assess the impact of systemic, particularly vasculitic disorders in patients, for example, with necrotizing scleritis or sclerokeratitis that may evolve with kidney dysfunction. So we may find casts in the urine sediment. It may also be helpful to rule out infections, for example, in Candida endophthalmitis, in which the frequent source of infection may be the urinary tract, as well as to monitor side effects of cyclophosphamide therapy. This stool test is not that much useful, but it may reveal co-infection with parasitic diseases. It may also be quite useful in highly endemic areas for strongyloidiasis, in candidates to high-dose corticosteroids, in which this therapy may lead to dissemination of strongyloidiasis. So these patients should be investigated and previously treated with ivermectin or albendazole. Molecular tests are being increasingly used with aqueous, vitreous, as well as tissue samples to detect the DNA or the RNA of infectious agents. We have been using this a lot for herpes viruses, but also for Toxoplasma gondii, Mycobacterium tuberculosis, fungi, and other organisms. So this is an example of a patient with multiple episodes of hypertensive anterior uveitis in the right eye. He had already undergone cataract surgery and had this kind of heterochromia, as you may see, and he had stellate and some coin-shaped keratic precipitates associated with episodes of hypertensive uveitis. So he underwent an AC tap, and it showed that it could detect the DNA, amplify the DNA of CMV, showing that this is a CMV-associated anterior uveitis. Another example of an old patient undergoing chemotherapy for a thymoma, and the clinician was very concerned about the possibility of a masquerade syndrome, an intraocular infiltration by the primary neoplasm. And she had this extensive necrotizing lesions in the peripheral retina of the right eye, as well as in the macula of the same eye. And we did an AC tap, which was negative for herpes viruses, and luckily positive for toxo, establishing a definite diagnosis of atypical ocular toxoplasmosis. Cyto and histopathology of fluids and extra or intraocular tissue may also be useful in management of patients with uveitis. This is a chororetinal biopsy of an HIV positive patient showing a full thickness necrosis of the retina, reactive granulomatous inflammation in the choroid, and in the necrotic retina we see T. gondii cysts, proving that this is a toxoplasmic retinal choroiditis. The samples may also be sent for microbiological studies that may include smears, special stains, culture, and even PCR. This is an example of a patient from our service that had undergone cataract surgery, developed chronic intraocular inflammation in the operated eye, was concerned of having a propionibacterium acnes endophthalmitis, but cultures were negative, and eventually underwent a capsulectomy. And histopathology of the capsule nicely showed the presence of filamentous fungus structures that were sequestered between the anterior and the posterior lens capsule, as you can see here. We can also benefit from systemic imaging, particularly to detect systemic involvement in underlying conditions. So the chest imaging, as with chest radiograph or CT, may be quite useful. This is an example of a patient with sarcoidosis with this diffuse involvement, and the biopsy did show non-caseous granulomas consistent with sarcoidosis. But we also may assess the brain. For example, this is a small child with congenital toxoplasmosis with this typical wagon wheel scar in the macula, but on the CT of the head, she did show hydrocephalus as well as gross periventricular intracranial calcifications. Multimodal imaging has brought a revolution to the clinical approach of uveitis in our field. So we combine different techniques so as to be able to delineate changes at the level of the posterior segment of the eye. Some of the images may be even almost pathognomonic of some conditions. So we do combine these techniques in a judicious way. This is an example of a classic case of posterior placoid syphilitic chororetinitis on multimodal imaging. So we are able to delineate all the changes, and with this combination of modalities, this is quite specific of the diagnosis. We may also use functional tests, electrophysiology, visual fields, microperimetry. This is an example of a patient with APM-PPE that we have a correspondence of the active choroidal lesions with the areas of decreased sensitivity in the macula. So when and how to investigate? So as I said, the approach should be rational, taking into consideration a careful history and clinical examination. Then we proceed to the clinical and anatomic classification of uveitis. We establish a list of differential diagnoses and then select the tests that should be used in that particular situation. So the clinical classification of uveitis proposed by the International Uveitis Group several years ago, it's quite useful in the clinical context, because first step is to rule out an infectious condition. The second step is to look for an underlying non-infectious systemic condition, which may be present at the diagnosis, but which may manifest many years later. And last but not least, more rarely, fortunately, to make sure that it is not a non-infectious condition that is leading to intraocular inflammation, what we call the masculine syndromes. The prototype of this group is the so-called primary vitreoretinal lymphoma. So as we showed in the previous presentation, the anatomic classification of uveitis is fundamental to help us in the clinical approach of uveitis. So this is an example of a 50-year-old woman with the first episode of a unilateral non-granulomatous anterior uveitis, had a negative medical history as well as negative review of symptoms. Should we investigate her? So this is the possible list of etiologies of anterior uveitis. Actually, most cases end up being idiopathic, but we have a few severe systemic conditions which may be associated. So one may not investigate patients with adults with the first episode of mild unilateral non-granulomatous uveitis with negative past medical history and a negative review of symptoms. This is because this is very likely associated with idiopathic condition. But however, if the patient is a child, if we suspect of any condition on medical history as well as on revealed symptoms, if there is moderate to severe inflammation, bilaterality, granulomatous inflammation, or the course is chronic and or recurrent, then we should investigate these patients. So how to investigate overall a case of anterior uveitis? CBC, ESR, CRP, HLA-B27, specifically in patients with hyperacute alternating anterior uveitis, ANA, the AC level to look for sarcoidosis. The main manifestation of sarcoidosis is indeed anterior uveitis. We have to look for syphilis. In any type of intraocular inflammation, syphilis may be the culprit. And also for assessment of TB with a TST or IGRA and imaging of the chest that may be useful to assess for TB as well as for sarcoidosis. Other tests are employed based on clinical suspicion, as an example, when we suspect of herpes viruses. What about intermediate posterior and panuveitis? Well, as a rule of thumb, this case almost invariably investigated. And why is that? Not only because of the potential severity of intraocular inflammation, because if it is an infectious condition, we'll probably use systemic corticosteroids. So we have to make sure that there is no occult underlying infectious agent that may be responsible for this uveitis before we consider systemic corticosteroid therapy. Also, in these conditions, we usually and frequently use multimodal imaging that, as I said, may also help in the establishment of patterns, of imaging patterns, some of which may even be diagnostic. So intermediate uveitis first. Many cases are idiopathic indeed, but some cases may be associated with infectious or non-infectious conditions. These are the most commonly found: syphilis, sarcoidosis, Lyme disease. Patients with neurologic symptoms should be assessed for MS, toxocariasis, HTLV, and finally, more rarely, hepatitis B and C. Posterior uveitis may be idiopathic, but again, as for intermediate uveitis, the idiopathic label is a diagnosis of exclusion. So possible etiologies include toxoplasmosis, syphilis, toxocariasis, cat scratch disease, herpes viral infection, TB, fungal infection, the so-called white dot syndromes, which are primarily choroiditis. And these conditions, they usually benefit from the employment of multimodal imaging, and vasculitis, which may be associated with underlying systemic conditions. And last but not least, panuveitis, which may be idiopathic, again, a diagnosis of exclusion, but may also be associated with VKH, Behçet's disease, sarcoidosis, tuberculosis, and syphilis. So this is an example of a young male with migrating retinal infiltrates in the left eye. As we proceed to the superior periphery, we could see the most recent lesion, and zooming it up, we could see this S-shaped larvae that is diagnostic of diffuse unilateral subacute neuroretinitis. So this is an absolutely clinical diagnosis. We don't have to do any investigation at all as long as we find the larvae. We did the OCT just to show the location of the larvae just below the ellipsoid zone, as you can see in this image. So the patient was lasered and was cured without any systemic investigation at all. So in conclusion, there is no standardized workup for all cases of uveitis. We have to keep calm, we have to think and take it into consideration a careful history and clinical examination, the clinical and anatomic classification of uveitis, the elaboration of a list of possible differential diagnoses for each case, and then proceed to a rational selection of investigations that will be employed in this context. Keep in mind, the investigations should be complementary. They do not invalidate the ultimate importance of clinical history and of clinical examination in our patients. Thank you very much for your attention.
Thank you, Daniel. So I guess this is the time to take up the questions, controversies, unclear questions. And I would also like to invite Mark. Welcome, Mark, who's our treasurer of IUSG and who joined a bit late.
Hi,
And
Mark.
Hi there.
Hi.
Sorry if I had to be late. I had some other appointments still.
No
A
problem.
fantastic session, I have to say. Very good speakers and very informative.
so we have lots of questions. Many of them would be answered by the speakers in Q&A box, but some of them I'm going to take up and Manfred is going to lead the discussion. Manfred?
Vishali, one second. I think we can probably bring some of these questions into the controversy.
Absolutely.
I think there is not so much controversy, but some of these questions are actually something where we may have a little bit different opinions.
Yeah.
So
you can start with
I can start with that one. Yes. So one point is, Danielle, you mentioned, I think Peter too, that we should not investigate the first active uveitis if it's anterior. Well, I think since years I'm a little bit different in this regard because I think it may be very helpful to give further analysis to these patients. Let me tell you, well, one point at first to everyone who has sent wonderful questions. A lot of these things will be discussed in the next webinars. They are super specific, some of them, for especially the viral ones. We have 2 hours to discuss viral anterior uveitis. So if you cannot cover all of your questions in this regard, please come back to the viral anterior uveitis, and then we will go much more into detail, the role of serologies and things like that. But let's go back to this first episode. Something which I discovered, and I think, Danielle, you mentioned that too, there is maybe a point that we should not analyze a first active anterior uveitis. Intermediate and posterior uveitis we should. So we agree to this one. But what about anterior uveitis? My help to analyze anterior uveitis is simply called laterality. So going on with what Peter mentioned already in his talks, I separate in unilateral, always more or less. It's a wonderful sign of viral uveitis. I think there is no controversy. This is really worse. And then I separate unilateral with changing pattern. And this changing pattern is very typical for HLA-B27 positive people. Then we do not have any problem. But again, Peter mentioned that too, a lot of these people are negative, but they fulfill exactly the criteria of this bilateral disease. So I call them HLA-B27 typical disease, and I treat them exactly as being positive. And in addition to this one, if you're positive and a man, you have quite a good chance to develop one of these classical B27 associated disorders. But if you're negative and a woman, you still have a chance of, I think, 20% to develop ankylosing spondylitis. So B27 is more a marker for probably the associated disorders, but not for this classical, typical, clinically defined anterior uveitis. If you use this one, we hardly have a lot of idiopathic anterior uveitis anymore. And coming back now to your first episode of your patient, when we find such a pattern with the classical findings, which we will discuss later in other seminars, webinars, then this is a very critical, important information also for the patient, because we really can help him very, very often in advance, prophylactically. So in that regard, I think it's worth to even the first episode of unilateral disease, definitely. Can we have some mild discussion about that one?
Yeah, I'm happy, Manfred. I investigate every patient with uveitis.
Yeah, I think
and
so.
I think every patient needs syphilis serology, and
Yes.
every patient needs a careful systems review and a very careful history, because most of the time in that first episode, if there are clues, it's in the history. So there'll be,
Absolutely.
inflammatory back pain or other clues, or as you say, the clinical phenotype of the uveitis, you know, and other signs may give you clues that it actually is viral. So, you know, if there are coins.
Peter,
yeah.
How often do you see a uveitis, a patient that runs into your clinic that has a first episode of uveitis?
That's another point.
When was the last time you went into casualty in the you know, and
well,
you had to
my fellow, we see a new one. Yeah, we see a new one at the hospital every day. And all of those patients, the fellow obviously works up. I never see them. They don't. We try, you know, it reminds me of when I was a fellow at Moorfields, and I was told your job is to be a wall, and your job is to keep all the acute anterior uveitis, or as much of it as possible, out of our uveitis clinic. And they gave you a set of rules to do that. But I think it is being serious, working at having a careful history and clinical assessment, and at a minimum, you know, syphilis serology. At our hospital, 1% of our acute anterior uveitis patients end up having syphilis. So it's 1 in 100. So, you know, that's we see several every year.
Yeah, this is so important that we have our own webinar about syphilis. You will see that.
Dr. Biswas,
because the question, I think, in part is, you know, we're uveitis specialists, and we see subspecialty cases. And when we see a patient that comes in with some cells, you know, if you just had, let's say, trace cells in an anterior chamber, for somebody in the periphery, they may see that as a uveitis, and it may go away with just steroids. And so, you know, but on the other hand, your syphilis case and many others often will be worse, and they will come back if they're not responding to the steroid. They'll probably be referred to you. So I think in part the question is broader. You know, it's what do we do as uveitis specialists when we see uveitis, which is examine every single patient and assess them. What should somebody do if they're out in practice somewhere on the face of this earth and they see a patient that presents with just a few cells in the anterior chamber? Should they do a full workup? Should they just try steroids and see if they respond well? You know, I think the situation is different. In that setting, for a, let's say, a first-year resident, maybe just trying steroids is acceptable. What do you think about that? Just to push the controversy a bit further.
Well,
what were you told
it's
in your fields, in fact? Did you have to bring them in and examine them, or just treat them, Peter? Tell us.
Look, I agree. I see we see a fairly specialized cross-section of patients, and at the eye hospital, we tend to see the ones that are either very severe or haven't responded to topical steroids. I agree, even with their anterior uveitis. So you're right, we probably don't reflect what happens out in the big wide world as accurately as, you know, a community clinic in a stable, you know, community-based population. I think you mount a perfectly reasonable argument to do that. But I mean, syphilis, I suppose, is a good and a bad example. You know, the patient may not get another episode of uveitis for a long time and may present then with, you know, neurosyphilis or other sort of much more advanced disease. So you can argue both ways. So I think it depends on where you are, what resources you have. Your approach is reasonable. The other approach is reasonable. Yeah.
I think you all agree that bilateral anterior uveitis needs investigations. So that's no question. Yes.
Yeah.
But please be aware that this is probably 10% of your anterior uveitis patients only. One more point of concern is I see a lot of HLA-B27 positive patients, even with ankylosing spondylitis, which unfortunately do not have uveitis which fits to that phenotype. They have HSV uveitis, they have high pressure and so on. So please be careful, but I would like to go on to the next things because this is something which will come up with the next webinar again, and then with the B27 again. Can I probably go on to something else, which I think is very important here?
For a moment, Manfred. Daniel, can you please answer, because there are a lot of questions mainly for you that do not discussion. So can you privately answer them, please?
Yes.
privately outside of this discussion, yes?
Yeah, I will. Yeah, definitely.
Okay.
Yeah, don't worry. I'm gonna do
So let me add one more point, and this is also a point of, I think, for our discussion. Do you agree that nearly hardly, rarely, one of the anatomical location changes? So that, for example, from anterior uveitis, you go on to intermediate uveitis, and then you go to posterior uveitis. These are absolutely different disorders. If they change, think about sarcoid and tuberculosis. The other ones extremely rarely change. This is, please, important, number one. Would you agree to this one?
I think that also has to do with the nature of the, I mean, of the clinic. We are all uveitis specialists. We usually get referred patients. So by the time they come to us, some time has passed. But if you look from the other side of the coin to a patient presenting very recently, sometimes I've seen a bunch of patients that present apparently with an anterior uveitis to a first specialist, and then they're referred to me. By the time they come to me, things change. So we have to keep in mind that uveitis is quite dynamic. I agree that there is a time that it does stabilize, and then it does crystallizes as an intermediate, posterior, or anterior uveitis. But sometimes, very in the beginning, we may have some differences in labeling if it's either anterior or posterior, particularly the first physician who is seeing the patient.
Well, it may start as anterior uveitis with a few cells, but then you may have overlooked that something going on in the vitreous. So it was already intermediate uveitis and you have a spillover phenomenon. I agree that sometimes you develop from anterior uveitis to panuveitis. Yes, and sometimes you develop you see anterior chamber cells in toxoplasmosis, for example, but you may have overlooked that something's already going on in the choroid. So again, I think there is hardly any change of the anatomical sites from one to the other immediately outside, with the exception that it gets worse, that it gets panuveitis, of course.
Manfred, there are two questions related to it.
Yes.
Is anterior uveitis with cystoid macular edema?
Yeah.
Or there is capillaritis on fluorescein angiogram? Or there is disc edema? Would you change it to posterior uveitis, or would you?
Can we quickly give this to the discussants? We have to separate very, very clearly. This is learning the language of uveitis. We have to separate the anatomical location from the complications. Every complication we know, the complication we know is, besides cataract and glaucoma, also optic disc edema and macular edema. For posterior uveitis, you absolutely need chorioretinal or retinal infiltration. Otherwise, it looks like a complication of your intermediate or anterior uveitis. So please don't use posterior uveitis if your patient started with anterior uveitis and then later on the macular edema. The right naming is anterior uveitis plus, as a complication, cystoid macular edema. Can we agree to this one too? Yes. I hardly see any JRA kids without optic disc edema. They get it super easily. Yes, this is very normal. I do not even follow this. This is not a major criteria for my treatment, but these kids also have a lot of cells in the anterior chamber. So this is the real criteria for this one. And they probably may develop later on cystoid macular edema. So I think that's an important point.
I agree.
Any questions in this regard? Did you see this?
No, I'd just like to come back to one thing, because, when you're saying there's no change in location, we were talking about anterior, posterior, but in certain diseases.
Anterior intermediate, sorry.
Okay, anterior intermediate, because, one has to be careful. We also talked about toxo and other things. Something like toxo can start in the choroid, move into the retina, end up in the vitreous. And so certain things do move, particularly infections, from one compartment to another. And I would agree with Danielle that, you know, an early presentation can change, but once it's set, it sort of is in one key area, and that's the area that is the most inflamed. So even in this discussion of trying to put it into one category of another, it also has to do with where seems to be the most important inflammation. You know, Danielle had that question about anterior uveitis, and then after that, you sort of see something in the vitreous. Is it iridocyclitis? Is it iritis? It's a fluid type of diagnosis, and it will all, of course, you'll have some other areas that can be involved. So it goes along the complications you were talking about. I don't think we have to be too fixed on location. We have to look at the syndrome, what's happening, where is it coming from, where is it going to?
And many a times it will also depend what treatment are they receiving. Like if you are treating anterior very aggressively, like VKH, for example, you have treated the posterior segment, it moves anteriorly.
Yeah.
So with this,
So that's a good example. I think it's a great example. You know, acute VKH is posterior, and very often when you get to the chronic stage, you see a lot more in the anterior segment. You still see some changes posteriorly, but we're more concerned anteriorly. So there can still be some shift, yes.
and you know, Mark, like you said, the older textbooks came from tertiary care, which defined VKH as bilateral granulomatous panuveitis. And I would look for it, and there is nothing like it. You may just have some capillary swelling, and probably it depends where you are looking at.
I
So,
think, yeah, I think that's very important too. I mean, you know, if you take even, for example, pars planitis,
yes.
you know, I've only seen one case in my career where I've seen a serious retinal detachment due to anterior, at the level of the ciliary body, constriction of the vitreous. And yet, if you look at some of the older textbook, this was the pathopneumonic definition of a pars planitis. So it has changed over time, in part because we're better at diagnosing it and treating it early. Steroids made a huge difference for this.
Right. Manfred, there is from Dara the suggestion about what Peter presented questionnaire. Could we have the questionnaire before patient comes to clinic, and would that help?
Can I ask first, who is using a questionnaire from you in your patients?
Not me.
Not me.
No, why not?
I used to.
I don't use
I
the
used to, but
questionnaire
I'm
for
not doing it
uveitis.
yet.
Well, I think
don't
it's
use,
easy. It's easy,
Yeah.
especially if you're not too much involved in uveitis. It's easy if you have a standardized questionnaire for yourself, if you're something with quite a learning curve, to find out and to learn about your patient. It's something which a patient can do probably at home already. Again, very helpful. And I think it also tells the patient that you're taking care for him, that you really try to find out if there is something. It's only of value, I think, when you really go through the whole questionnaire. You know, diarrhea, where has people always have some kind of once a month or something like this diarrhea, but if they have it every day, it makes a big difference to this one. So let me summarize the questionnaire. I think whoever wants to use it, it's fine. We use it. I think it's interesting. It's fine, especially also when you have a lot of patients and you have to standardize your procedures for such a lot of patients, using also the help of younger persons to go over these things. And we start now with the ISG to develop not the questionnaire, I've learned that one, but some kind of questionnaire which can be added, changed, probably depending on the countries, the continent where you live. And I think this can be very helpful. It's an offer from us. It will take a few weeks, I think, to get a good agreement, but then you will find it for download also on our website. That's my short comment to the questionnaire. It ends up with, you can do it as you want. Even in my hospital, some people use it and some don't use it. I think it's very interesting. There are always some good things in which you probably overlook. That's any comment to questionnaires?
We look forward to the questionnaires.
Yeah, we are working on that one. So we are in the situation that we try to bring in all the questionnaires which are available in societies which are in books, something like that, and to compare that, and then to make it a little bit more different by the societies where people live in. One more question, which I think is very important. Sorry?
Yeah, I just want, go on.
Yeah, serology. Is there any role, forget TB, forget syphilis. That's clear, we discussed that, absolutely. Is there any other point where you use serology for finding out the reason for your uveitis?
No.
No. What about herpes virus? Serology,
I mean,
CMV,
sometimes
wonderful.
get it done.
Don't use it. It's irritating. It's completely irritating. It doesn't bring any information. Please.
I tell you, when I use it, when I really want to treat the patient, it looks clinically to me herpes, and somebody says, okay, serology is also positive. I kind of feel good about it, but it doesn't help.
Yeah. No, I think I
If
see a
the
lot of
positive
wrong
result-
diagnostics here in this regard. Yes.
Absolutely.
Yeah, and that's not
Completely.
only for herpes. This is for toxoplasma. This is for TB and all those infectious conditions. I think
Danielle,
that serology only shows evidence. Oh, sorry. Yeah, can you hear me?
Danielle, can you comment to the role of toxoplasmosis serology? Any role and when?
So once you have the very typical presentation of a focal necrotizing retinal choroiditis that is satellite to a pre-existing retinal choroidal scar, this is very likely toxo. And in some cases, I don't even ask for serology. I live in a highly endemic area for toxoplasmosis. Around 50 to 80% of the population is seropositive. So it does not help me that much. However, seronegative results are very helpful. So if I'm not sure if it's like vitreous very hazy, I don't see much of the lesion, the characteristic of the lesion, I'm not sure. Many times I do order the serology because if it's positive, it does not confirm. But if it's negative, it does rule out, even in immunosuppressed individuals. So the IgG is quite sensitive, even though it's not specific for toxoplasma. And I have to also to add, there were some questions on that the IgG titers, they do not matter at all. They are usually high, they don't get up once the patient has a reactivation. So we don't look at all at the IgG titers.
I think the last thing which a lot of people are questioning is about the role of vitamin D. Would you do the serology for vitamin D? Would you treat it? And especially when we are putting the patients on corticosteroids, the vitamin D might be going down. So how seriously you take it? John, it starts with you because
I think it's an emerging, I think it's an emerging area, so I don't really know yet. The epidemiology showing that it might be a risk factor for developing uveitis, it doesn't necessarily mean that it will work as a treatment.
Well, can I shortly comment to this one? When I see my patients, I regularly give the steroids. I regularly give vitamin D, number one, as osteoporosis prophylaxis. Number two, we know that I didn't want to name this virus, you know which virus I mean, yes? That vitamin D is protective for this one. That's the next point. And then when I go through the whole medical things of my patients, can I tell you that at least half of these patients take already vitamin D? It's amazing. So the deficiency of vitamin D is worldwide tremendous. Yes. To all doctors, I talked in India about this one, where you really have some good sun. Yes. They say, well, sorry, we have vitamin D deficiency. We have to take vitamin D. So I think it's very, very difficult to tell if vitamin D has anything to do with uveitis. Very, very difficult.
Yeah, you can also look at other fields. I mean, if you look at neurology and MS, for example, they will prescribe vitamin D to all of their patients. And there is, if you look at it from a basic science standpoint, low levels of vitamin D is associated with a pro-inflammatory state. So there is some background for it, except that in the uveitis world, we haven't been able to do large enough studies to be able to determine whether it makes a difference or not. One other point is that, I've tested quite a few patients here in Switzerland, and the majority of them are on the low end of what's called normality or below, so that supplementation makes sense. And because we all are indoors more and more, even what is considered normal is probably on the low end of what we should have as vitamin D. So if the range goes from, let's say, 50 to 150, to have a good level, you have to be around 100 and not at 50. 50, you're already in a sort of a deficient state. We need large studies to be able to show. So, with low N numbers, yes, it does seem to make a slight difference in terms of how patients respond if they're not responding well to treatment. But, it would be nice to set up something where we can really show on a worldwide level whether doing something with vitamin D makes sense.
I think it's very difficult, really, because when I have my patients and they analyze vitamin D and it's on a low side, then I tell them simply, independent of all your diseases, take some supplements of this one. I think that's the easiest way. And if they
that's
have
just the
less,
point, is that, we're not trying to hyper treat because you can get into toxicity. You want them in a normal range. So how do you go from there? Because that takes a few months, really. How do you go from there to show that it makes a huge difference in terms of uveitis? I think,
that's the point of
we
studies.
have to think about
Yes.
that. And I agree with John that we haven't proved it, but there is some evidence to suggest that it might be helpful. But, that's as far as we can go.
I would supplement this in these patients. Okay, I think we are nearly reached our time. I would like, thanks, really, we had a lot of participants, 650, I think. This is very nice, 670 sometimes. I hope you enjoyed this session. This was a first. There are a lot of sessions to come. I strongly suggest for you to listen at least to these basic uveitis webinars. The next one will be on the 6th of February. If you want to have the CME points, you know that you have to send the questionnaire to us, this evaluation sheet, and then we'll send you the document of participation and the CME points, which I think 2 per webinar will be sent back. We had to probably not, we were not able to go.
Evaluation?
It's evaluation.
You
You
will
got
be
that with your registration already. Probably you not, but all these participants, they got it when they registered. And so I hope that you know what I mean. There were probably a few questions which we did not answer. If you join us the next time, I think they will fit to these next topics.
I have answered most, Manfred. I have answered majority, but there are few which will be taken up on specific occasions.
Okay.
I think Peter has to answer the one on why dental examination.
Sure. Yeah, it's basically, it can just be a source of infection for metastatic endophthalmitis, endogenous endophthalmitis, particularly in anyone who's immunocompromised. And the classic is people who are on, TNF blockers for arthritis or inflammatory bowel disease, and they come in for the first time with uveitis, and it's pan-uveitis, not anterior uveitis. So you immediately need to think about infection as a cause. And so if they've, had dental work and had, teeth extractions and root canal therapy without antibiotic coverage, and they're on these drugs, I've seen that twice now in patients.
Thank you.
And also, of course, you've got to look for infection elsewhere, endocarditis and the brain and the kidneys and things.
I just see again the questions. If there is a recorded version of this one, yes, you can get that on YouTube. Yes, all the sessions will go on YouTube. Vishali?
Manfred, we will put the YouTube link on IUSG website.
Perfect.
So they have to visit the IUSG website and click on the link to watch it on YouTube.
So I hope that everyone who missed that session, unfortunately, can see us again then on YouTube. I hope that all of you more or less enjoyed this session, and we hopefully see you back on beginning of February. Again, we try always the first Saturday per month. it should be always between 1 or 2 o'clock Central European time. Depends a little bit on the participants where they come from. Thanks a lot to everyone. I hope you have a lovely, safe weekend.
We would also like to thank our audio team and global conferences for doing all the backstage work for us. Thank you.
Thanks so much to all of you.
Thank you.
Thank you.
Bye. Take care. Good
Bye,
night.
everybody, and keep safe.
Sleep
Take care.
well.